All right, so as far as the part 3 exam is concerned, we know that we have to practice. Okay, we have to be practicing our stations, and now that the exams are just a few days away, we have to be practicing our stations and practicing at least 10 stations per day. That is the target that we had set when I was answering the exam. My study partner was Dr. Uma. So I was studying with her and we had set this target. Of course, I was working and I had taken some 15 days off, and that's when we were only concentrating on practicing stations. And yes, practicing recalls helps. All right. The thing is that you need to practice in the right manner. Okay. Do not read anything new right now. If you just want to brush up whatever you have studied so far, just go through the whatever notes that you have made, or if libraries that you have subscribed to, any courses that you have taken, just go through the notes that are available with you and practice in the right manner. That is the key. All right. Now, let's look at things where we tend to make mistakes. Now, this is one of the things that we have noticed in the part 3 exam, is that some of the candidates overemphasize on communication aspect. Now, what does that mean? Okay, now if you look at part 3 exam marks distribution, it is something like this. There is information gathering, there is communication with patient or communication with colleague, patient safety and applied clinical knowledge. All the 4 domains have equal weightage. But some of us think it is something like this. This is not the right thing. For example, I'll give you an example. Like if there is a station, say a patient has come with cancer, for example, and you know that you have to empathize because she has cancer, and you have broken the news, and then you go on and on about, I'm so sorry, I will try my best to help you, I know this is a difficult situation. These are things that you should say. I'm not saying you shouldn't be saying, but don't drag it so much that that you ignore the other aspects. Like you don't get time to cover the rest of the points. That is why you lose on patient safety and applied clinical knowledge, because you emphasize so much on the communication part that you sometimes tend to ignore the patient safety and applied clinical knowledge bit of it. Okay, it is very important to empathize and sympathize and all those things. I agree with you, but not at the cost of your the rest of the station. So the applied clinical knowledge, patient safety are important domains. Information gathering, yes, it comes in the beginning of the station. So that is usually covered. But after that, you start all your communication and this and that. Even while you're doing the information gathering bit, just say a simple small sentence. Don't worry, we are trying to help you, and something like that, and proceed. It's important to proceed with the station rather than hovering over the same issue over and over again. Okay, so that's one message that I would like to give to all of you. Another thing that we have noticed is when the role player reacts, or she is in a situation where she's angry and she's disturbed, do not become over defensive. Don't say, oh, sorry, I'm so sorry, I will try and investigate why this happened. First, listen to what the role player has to say. Okay? If you act defensive, it on the contrary, it looks like you are at fault. Most of the times you are not at fault. Okay? This patient may react in that manner because of a situation that she is in. You have to calm her down. You have to counsel her. You have to tell her that please, I'm here to help you. I will address all my concerns. I would need certain information from you. Is it okay if we proceed? Okay, if she's angry, so say, I'm really sorry that you are feeling so. I will try my best to address your concerns, and then proceed with the station. Don't keep on saying, we will investigate, we will do an incident report, this, that. Not in the beginning. I mean, you have to say these things, but do not overdo it. Do not become over defensive. That is a typical trend that I have seen in most of the candidates. Okay, do it, but remember, you have to cover up for the rest of the station. You have to cover all your points. Ultimately, remember, part 3 is a tick box exercise. So the number of points you cover That is what it is about. Okay, of course, you have to cover your points in an empathetic manner. Hello, can you hear me now? Yeah, okay. I think there was some network issue temporarily, hopefully. All right. So the gist of this is that you should not be overemphasizing on communication. All right. Now, the next thing that we typically do is this is a major problem, most of the stations. Okay, situational awareness. Now, what does that mean?
Ma'am, you are not audible.
Hear me now? Hello, you can hear me now? All right, all right. Not quite sure what has been happening. Anyway, um, there is no problem with the net at least. Anyway, okay, so okay, so I was saying that the next important aspect is situational awareness. Know your limitations. You are the SD5. When it comes to complex decision making, you have to realize that you are not the consultant, and you are just the ST5. So, for example, when you have to take a decision for referral to say bariatric surgery, or you have to take a decision where you would need to refer her to say a fetal medicine specialist. Okay, you as an ST5 can advise the patient about the plan. Okay, but you have to involve your consultant in the decision or in the referral that you are planning or thinking of planning for her, for the patient. So that is important. You have to realize that you are not the consultant, although most of us today are probably already consultants. Okay, and that is why we have the mindset that this is what we would do. Okay, but remember, in the exam you are the resident there. Okay, and when it comes to complex decision making, you have to involve your consultant. Okay, like simple things like delivery of a patient with preeclampsia, certain threshold has to be decided. So you have to involve your consultant into the decision making. So that's important. Remember that. Okay. Now remember where you are. A common mistake I'll tell you, when a patient is, it is told to you that you are on rounds in the ward. Hello, hello, hello. Okay. Okay, so for example, this was this lady, there was this lady with structured discussion, and it was a twin patient. She was DAMC twin, and she had TTTS. So there, some of us would go and say, okay, I would admit this patient. You have to be aware that you are in the ward and the patient is already admitted. So when the patient is already admitted, please don't go in and say that you have to admit this patient. Okay, that is another common, very, very common mistake. These are simple things, small things, but the examiner would note these things. Okay, and remember for the part 3 exam, there is not just the domain wise score, there is a global score. It is important how you impress the examiner as well. Okay, so don't make that mistake. If you are in an A&E, say for example, you are seeing a patient who has come with a hemoperitoneum, and then you say that, you act like, or you start by saying, I'm here, I'm one of the doctors here in the clinic. That's again a wrong thing to do. Okay, so avoid doing that mistake. So where you are is important. Now, as far global score is basically, somebody is asking what global score means. Now, global score is it's a overall assessment of how you have.
Ma'am, you're not audible.
Let me see if there's a problem with the settings, and I don't know why this is happening. Hello, can you hear me now? Okay. You know what? I'll just move to a different place. Maybe this issue will not happen. Okay. Okay. Fine. So, yes. So when you are in the A&E, for example, you will say that, hello, I'm one of the doctors here in the emergency. Or if you're in the ward, you'll say, hello, I'm one of the doctors here. Or it's best to say, because you would be, tensed up, and when you're answering the exam, it is best to practice by saying, hello, I'm so and so, I'm one of the doctors here. Don't say where you are. Okay? Because in the exam, if there is such a situation, then you may confuse things. Okay, because you are anyway anxious at the time of exam. Okay, so the best thing to do is while you are practicing now, start introducing and say, hello, I'm so and so, I'm one of the doctors here. Okay, there. Important to understand this. This is another important aspect which almost all of you all ignore. Okay, like the other day when I was taking the class on labor ward, I was talking to you about the different types of labor ward prioritization stations that are the different forms that are asked. Okay, one of them is where it would be a simulated colleague task where you are talking to the midwife. Okay, so it would be given to you that you are about to see your senior midwife and she has taken handover, blah, blah, blah. Okay, that would be given to you in the question. So you should be aware when you open the station, you should be aware that this is a simulated colleague task and it is not a viva, not a structured discussion where you are answering to the examiner. Okay, so you have to be starting that in a way you normally talk to your say patient or the role player. So you say, hello, I'm ST5, I'm on the labor ward, and you are I know, and you are, I believe you are the senior midwife and you have taken the handover. Then the senior midwife will tell you that this is what you need to do in the station, and then you proceed with the station. Okay, so it's important to understand who you are talking to. Okay, like in the Alzheimer's station, another recall where the patient's mother has, the role player's mother has Alzheimer's. You should be aware who you would be talking to in the station. It will be given to you in the station that you are about to see so and so, daughter of so and so. Okay, so don't go in and start by saying, oh, I believe you are having bleeding and this and that, because she's not the patient, she's the daughter of the patient. Okay, so again, that is also situational awareness. All right, then know the urgency of the situation. For example, if there is a patient who is having pulmonary embolism, okay, and she's breathless and she's acting breathless, you will not go in and and with your normal routine way say, hello, I am so and so, I am Dr. Ankita, I am one of the ST5 or blah 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 blah. No, you can say, go in and say, is it whatever, take her name, Mrs. Robert or whatever the name is, and say, is this Mrs. Robert that I'm talking to? You can confirm that way and say, are you comfortable now? I can see that you are breathless. I can see that you are in pain. Whatever the situation is, I can see that you've been vomiting. Okay, it depends on what the situation is. So accordingly, you have to do the station. Okay, so start the station depending on the situation that you are in other words, be aware of the situation that you are looking at. Also remember that in the 2 minutes time, a lot of you would have questions. What is to be done in the 2 minutes time? Most of you would be just noting down one. Okay, so you would be given a notepad and a pen, okay, in the face-to-face exam. And typical thing that a tendency of us to do is to note down points. Somehow I feel that does not help. What helps really is for you to understand what the station is about. Okay, so that really helps. All right, so that is important to understand the station. Read
This conference will now be recorded.
Okay, so this is what we were referring to, and I think we are finished with that, with situational awareness. Okay, so these are certain small things, but they would go a long way in, making, even if like you fumble at a point where you think that you are in A&E and then you said that you are in A&E while you are in the ward, and then the entire station I mean, you would mess up because then you would get all tensed. So that you should avoid doing. So be aware of the situation. So know where you are, know what the situation demands, know the urgency of the situation. Coming to this is a few things on concepts. Okay. This is something that I have noticed recently when I was assessing candidates. Uh, there is a misconception about the management of prolapse. Okay. And this is what we need to really understand. So there can be prolapse in three compartments. Okay. There can be prolapse in the anterior compartment, this one. Okay, if you can see my pointer. One sec. Okay. So it can be in this compartment, that is the anterior compartment. It can be in the posterior compartment, that is your rectocele, cystocele, your prolapsed uterus, that is the apical or the central compartment, and or the vault. If there is no uterus, it would be the vault. Okay. What we need to understand while we are doing our stations is management of vault prolapse or uterocervical prolapse is different from management of rectocele and cystocele. A typical mistake done by most of the candidates is that they would think that if there is a POPQ which is given, which is showing rectocele, or there is POPQ which is showing anterior prolapse, that is a cystocele, the management would be spoken of, the management spoken of would be of wall prolapse. So that should not happen. Okay, so that is something that we all need to keep in mind. Okay, so then going to the next thing, let me tell you how the management would change. Okay, for the anterior compartment prolapse, that is cystocele, the treatment is anterior repair or anterior colporrhaphy. You can use the word anterior colporrhaphy, or even better would be anterior repair, because that is a standard term universally used, and it involves lifting up the front wall, that is the anterior wall. While you're explaining to the patient, you can say the lifting up of the front wall of the vagina and suturing it back in place. This much is enough. That is anterior repair. Okay. If there is a vault, if there is a patient who has undergone hysterectomy and now she has come with cystocele, please don't tell her that you would do a sacrocolpopexy or a sacrospinous fixation. Okay. Anterior compartment prolapse does not mean she has a vault prolapse. Okay, that is something we need to remember. Then posterior compartment, rectocele, the treatment is posterior colporrhaphy. Okay, then vault prolapse. The treatment of vault prolapse would be either a sacrocolpopexy or sacrospinous fixation. We all know this. Okay, so sacrocolpopexy is done abdominally. Sacrospinous fixation is done vaginally. Okay, sacrocolpopexy would require use of a Y mesh for the two arms of the Y would go on the anterior and the posterior surface of the vaginal vault, and the stem of the Y is suspended to the spine. That is how the vault gets suspended to the spine. Okay, so that is your sacrocolpopexy. In sacrospinous fixation, the vault is vaginally suspended to a ligament in the pelvis, which is the sacrospinous ligament. Okay, so remember, sacrocolpopexy is done abdominally, sacrospinous fixation is done vaginally, sacrocolpopexy can be done laparoscopically as well. Why we need to know this? Because sometimes you get cases with complex problems, like you get cases of rectocele with walled prolapse, or anterior compartment, that is cystocele with a little bit of walled prolapse. Okay, if you are talking about surgery, for example, for rectocele with walled prolapse, you would say that you would lift the rectocele back in place. So you would do a posterior colporrhaphy for the rectocele. Along with that, if you go in vaginally, you can do a sacrospinous fixation at the same time, so that the vault is also fixed higher up in the pelvis. Okay, it does not really make sense to do a repair of the rectocele vaginally and then give another incision abdominally and do a sacrocolpopexy. So this basic idea you should have, basics you should know. You need not know the complex procedures. You need not know the details as to how this is done, but you need to have an overview of the basics of the surgeries. Okay, so sacrospinous is something that you can easily do while you're fixing the rectocele, because it is from the same incision that you go higher up and pick the apex of the vault and fix it to the sacrospinous ligament. That is how a sacrospinous fixation is done. Okay, then. Okay, so if there is a descent where the uterus is there, then it will be sacrohistropexy. Okay, that means you are lifting up the uterus and with a mesh, you are suspending it on the spine, anterior ligament of the spine. Okay, so that would be sacrohistropexy. Okay, now there is another common problem or common station that is asked in the exam, that is SUI with cystocele. Now, whether to offer treatment of both is controversial, because if you read the NICE guidelines carefully, it says that you need to seek MDT opinion, and there is no definite consensus about offering both the surgeries together or sequentially. Okay, SUI surgery is not the same as cystocele repair. Okay, cystocele requires you suturing the fascia which is defective. Okay, basically it is site specific repair, the anterior repair. Okay, while for SUI you need to strengthen the mid-urethral support. Okay, so that is why you put a mid-urethral sling, the retropubic mesh repair. That is what is done in SUI. Now there is a common misconception. Birch-Colpo suspension, if there is cystocele, you say, and there is SUI, most of the candidates will say Birch-Colpo suspension. Am I still not audible? I think because some of you are messaging that I'm not audible. I believe I am. Yeah. Okay, fine. All right. So, Birch-Colpo suspension cannot be used to treat cystocele and SUI. Birch-Colpo suspension is purely for SUI. Of course, if there is a transverse tear high up in the pubocervical fascia and then you are lifting it up, maybe then it will treat the cystocele. However, if there is a lower defect in the vaginal wall, in the fascia, it may not treat the cystocele. So what you basically, all this complexities you need not know. What you need to know is Birch-Colpo suspension may not always treat cystocele. Birch-Colpo suspension is a surgery which is done for SUI. Okay, and for cystocele, you need to still do anterior repair. Okay, if you're doing an anterior repair which is done vaginally, you might as well do a retropubic mesh repair for the SUI. Okay, because you are anyway doing the cystocele repair vaginally, because cystocele repair is mostly done vaginally. Okay, now another question is mesh. Where is the mesh used? Where is the mesh not used? Okay, remember, for the anterior and the posterior compartment defect, anterior prolapse and the posterior prolapse, you would not use mesh routinely. Okay, how would you tell the patient? You tell the patient that if she has a cystocele or a rectocele and she asks for mesh, this is a typical role player question in the exam. So you would say that because of safety concerns, we do not routinely use mesh for anterior repair or the posterior repair. Okay, after having explained what anterior repair and posterior repair is. And you say that in case you do wish to participate in research, then yes, then we could we could suggest the use of mesh for you in case you do wish to participate in research. That is how you would say it. All right. So mesh in urogyne for us, okay, mesh may be used in many places, but for us, for us as ST5s, it is used in 3 places only. As I mentioned earlier, in sacrocolpopexy, where you use a Y mesh, where the 2 limbs of the Y go anterior and posterior to the vault, and the stem of the mesh is hung on the spine. You use in sacrohistropexy, that is where the uterus is intact and uterus is hung with a mesh onto the spine. And thirdly, you use it in retropubic mesh repair for SUI. These are the 3 places where you use mesh for all practical purpose. Anterior and posterior colporrhaphy, you do not use mesh. All right. So this is what it is. Okay. This has to be very clear because these are common stations that are asked in the exam. Other important things that I would like to touch upon is MOH protocol. Always there in the exam as in the labor ward prioritization stations, or maybe they would ask you in some other obstetric emergency, some other station. There are these 4 components that you need to remember. You can refer to the YouTube video that I have made, okay, and how to say things under each of these components, okay. So you say, I would active whenever there is a MOH, okay, more than 1.5 liters of blood loss. You say, I would start the major obstetric hemorrhage protocol, and this is an obstetric emergency, and I would start the 4 components, that is communication, resuscitation, sending investigations and monitoring, and arrest of bleeding. The last word is most important, all simultaneously. Okay, you cannot say that I would first communicate and then resuscitate. No. Or you can't say that I would resuscitate first and then communicate. All the 4 components have to be done simultaneously by assigning tasks to the team. Okay, so say communication, this. Resuscitation, airway, breathing, circulation, lay the patient flat, pass 2 wide bore IV cannulae, give fluids, that is crystalloids, 2 liters followed by 1.5 liters of colloids, oxygen, blah, 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 blah. So it has to come in this manner, in this speed. It has to be practiced. Okay, so yeah. Then the next thing, another important typical problem that happens is when there is a preconception counseling station in maternal medicine, okay, the domain. I mean the maternal medicine module. What we do is we talk a lot about the antenatal management, we talk a lot about intrapartum care and a postpartum care, you know, how, the way we are taught to do maternal medicine stations. What we forget is the preconception period where the patient is actually come to you for preconception counseling, and we forget the preconception period. What we need to do, typically the patient would be unfit for pregnancy. Like example is sickle cell anemia. She's on hydroxyurea. You know the patient is unfit for pregnancy right away because hydroxyurea is not entirely safe for the pregnancy. You need to tell her that you may have to review her medications with the specialist, and in the meantime, while she's on the medication, or as we taper the medication and stop the medication, we need you to be on certain contraceptives. We could advise you regarding the contraceptives till you get a green signal from us. Please do continue the contraceptives. Okay, so that is a very, very, very important safety point. You need to advise contraception till the patient is fit for the pregnancy. So you need to do that in the preconceptional counseling part. Okay, then another important, a very important point. Okay, and this is something that I think all of us have queries about. Prioritization in labor ward prioritization stations. Who would go where? We are always confused. Okay, don't be confused. Okay, remember the mother who is critical will get priority. Now by mother who is critical, I don't mean a mother who is pre-eclampsia and who has a very high BP. That is a priority, but that patient, you can assign task to your junior to do certain things like give her labetalol, give her magnesium sulfate, send her investigation. You can assign the task. While a patient who is bleeding actively, that is a patient where you need to be actively involved, right? So you as an ST5 will go to the room where the patient is so critical that she requires active management from you. Okay, so you would go to the room with the patient that is bleeding heavily, where there is major obstetric hemorrhage. Again, in a labor ward board, if you see, there will be one room with major obstetric hemorrhage. Most invariably, not always, invariably, mostly, you will have one room with major hemorrhage. Okay, so where the patient is bleeding actively currently, it's a postpartum hemorrhage, you would go to that room. And please don't say, this is another typical mistake that most of you would do, that I would send anesthetist there. You cannot send an anesthetist to a patient who is bleeding from the uterus because the anesthetist cannot do anything about the uterus. Correct? Anesthetist can resuscitate a post-op patient. Post-op problem, you can send an anesthetist. Post-op patient has bled and now there's nothing obstetric that you need to do. Maybe you have to re-explore her, reopen her. That is a different part. There is nothing obstetric that you do in a post-op patient. For example, the patient who's having intraperitoneal drain with say 2.5 liters of blood, which was a recall. Okay, so there you can say that I would send my anesthetist because there she requires resuscitation like any other patient would require resuscitation. Correct. There is nothing obstetric that you are going to do there. While in a patient who is actively bleeding after a delivery, you need obstetric maneuvers. You need that compression, bimanual compression of the uterus. You need to tell the nurse or the midwife to give her this drug, this particular oxytocin, methergin, carboprost, blah, 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 blah. So that there you would be going. Don't send the anesthetist to PPH. That's a common mistake made. Do not send the anesthetist to patient antenatally who has very high BP. Preeclampsia is our area. It is our territory. We as obstetricians should manage preeclampsia, severe preeclampsia. Okay? Do not send anesthetist to a patient who is having very high BP or who is having PPH actively postnatally, post-vaginal delivery. Okay? Post-op complication, you can send an anesthetist. Similarly, remember, senior midwife is not just another nurse. Senior midwife is somebody you need to look up to, is a very, very, very experienced person. That's a senior midwife. And senior midwife can handle a patient with pathological CTG. So if you think that you are occupied elsewhere and there is a patient who's having a pathological CTG in some other room, you can send the senior midwife to that room. Because if you read the NICE guidelines carefully, again, suspicious CTG can be attended to by senior midwife or should be attended to by senior midwife or the consultant, while if it is pathological, then it has to be attended to by senior midwife and consultant. And let me remind you, in the NICE guidelines, they have highlighted or and in bold if you read the guidelines carefully. So senior midwife is not a small person. Senior midwife is not just another nurse. We are not used to having this midwifery system in our country, but this is something you need to remember, that senior midwife is quite a senior person, and senior midwife would help in managing a patient with pathological CTG. For that matter, if you are having any other obstetric emergency, while you are handling one patient, you can always ask the senior midwife to have a look at the other patient who has an obstetric emergency. For that matter, even a case of cord prolapse, what you need to do is you need to just transfer the patient to the theater. The preliminary steps can be done by the senior midwife even, or your junior, your ST2, your ST3. The preliminary steps. You say that, yes, this is what we need to, let me, is the meeting unlocked, Dr. Uma?
Yes, I did that.
All right.
I did that. Yeah.
Okay, fine. All right. Okay, so this is what I've been trying to tell you, that this is another important area where we have difficulty. So you would go to the room where the patient requires immediate attention, obstetric attention. Okay. then you can send the senior midwife to the room where there is pathological CTG. Consultant may be there, may not be there, but if you think there is an emergency, think rationally. If you think there is an emergency where you need a third person, third competent person along with you and the senior midwife, another person, then please call the consultant who's already there on the previous day duty. Like for example, if it is 8 o'clock in the morning, there would be a consultant who's on the previous day duty who would be around. So if your consultant is running late, you can call the consultant who is there on duty. Okay, so that's another thing that you need to remember. Anesthetist can manage your OT because there would be some patient you would need to shift to OT. So anesthetist can manage OT. Remember, there is an anesthetic consultant as well. So if you think that there is one person required for OT, the other anesthetist consultant can have a look at the patient, at the other patient who requires anesthetic or resuscitation or post-op care or whatever it may be. Okay. But please don't say I would send anesthetist to the lady with high blood pressure or anesthetist to the lady with vaginal delivery and PPH. That is a typical mistake that is made. Okay. So also know the rest of the team. I've highlighted this point because it would be given to you. You have the ST2, you have the ST3 with you. And then in the exam, when you're answering, you will say, I will send ST4 to this room. There is no ST4 in the team at all. From where did you get ST4? Okay, that's a common mistake that you do. Most of you do. Okay, so since now it is face-to-face exam, most of you are answering face-to-face exam. You will have a notepad with you. Please put it on the notepad. Who's your team? If it's difficult for you to look at the question paper repeatedly, please have a look at the notepad. And also while you are reading the questions, while you will get an overview of the situation when you are reading the questions, there may be just simple sentences that are asked in the questions. Okay, in the question, the main question. But also look for clues, like as I mentioned in the previous class on labor ward prioritization. There would be clues given there, like basically things that you need to pick up, like patient is delivered but she has von Willebrand disease, or it may be written that patient has come with floating head in labor. Why is this extra information given? Because they want to see if you are taking that particular aspect into account and you are vigilant enough to ask, okay, I want to know the blood loss in this von Willebrand disease room. In fact, if I was in the if any one of us was in the labor room and there are many patients around and somebody had to tell me that there is a von Willebrand disease patient delivered, the first thing I would want to know is how much what is the blood loss of that patient, because typically von Willebrand disease patients bleed heavily. Okay, so that has to be your approach. Your approach has to be practical. Okay, so when there is a extra information given like that, do not think that okay, this patient is delivered and she's von Willebrand disease. Then you go in there and to that particular room and start talking about, okay, I will do factor levels. Please don't do that. You have to address the immediate problem. If she's bleeding, you have to activate the MOH protocol. Factor levels will be secondary. Of course, you have to liaise with your hematologist and ask for factor replacement and all that. That is there. That is another thing that you would additional thing that you would do for this patient. But first things first, bleeding, treat the bleeding. You have to compress the uterus, compress the uterus. First thing is bimanual compression. Remember that. Okay. So, right. Then yeah, this is another point that I've written here, that midwives can handle emergencies in the interim period. Like there are many things that you are handling. Okay, you can ask your midwife, you can give her the task of, okay, now you can, there is a patient with, say, cord prolapse. Okay, put the CTG. If you have done a PV, raise the head of the baby. Do not fiddle with the cord. These instructions you can give the midwife. Okay, so that is something you basically, for labor ward prioritization stations, you need to have a practical approach. Okay, think what could go wrong based on the information that is given to you. Like for our exam, I remember there was a patient who had come with leaking, and it was just mentioned that the patient is feeling unwell. She's 30 weeks, 32 weeks leaking, and patient is feeling unwell. Why is this information given? For you to realize that there may be something more to it. Patient may be in sepsis, may be having chorioamnionitis, she's leaking. Okay, so the examiner is trying to understand if you are looking at it, from in a different perspective. Okay, so that is important. So look for these additional information that is provided to you in the station. Okay, know your limitations, as I mentioned earlier as well. So if it is you are an ST5 and it is a super specialty modules like your urogyne, onco, maternal medicine. Okay, before talking about, you can always outline the plan of care, the plan of management, but you do not say that, okay, this is what I would do for you. You have to involve the MDT. MDT is always important in all these modules, always. Okay, do not forget MDT. You will lose on patient safety. Okay, so that's the thing which we have already discussed earlier. Okay. Again, complex referrals. I gave you example of bariatric surgery referral, then your fetal medicine referral. Please involve your consultant. You will not say, okay, so then I can refer you to bariatric surgery. No, you would involve your consultant. Know your limitations. Okay. Propose safe options. I'll give you an example. The placenta previa guidelines say that you can admit the patient based on various factors, how far she's staying, whether she's symptomatic, asymptomatic, etc., etc. Now there is a station which keeps coming in the exam, which is placenta previa with Jehovah's Witness with anemia. This patient has come to you at 36 weeks. As an ST5, it would be safer for you to say, I would like to admit her. Of course, you would discuss with the consultant before admission, but as a resident doctor, you would think that it is safe for her to be admitted. So please do it. Okay, it is better to be safe. You can always justify your actions. You can say that she's Jehovah's Witness, she's anemia, she can bleed anytime. I would want to admit her. Okay, so that's how. Then, this is something that I've already covered in a separate class, which is there on the YouTube channel. This is about structured discussion. Organization is very, very, very crucial in structured discussions. And that is something that typically goes wrong. Okay. So when further information is asked, start with history, examination. Please just don't say examine and blah, blah, blah. Examination in the presence of chaperone with consent, and investigations. Three components of information gathering. It's not only history. When what further information is asked, it is history, examination in the presence of chaperone with consent, and investigations. If you do not say examination and investigations, you will not get your full score in information gathering domain. Okay. So another important point is when information gathering is assessed as a domain in a structured discussion. If the first question put to you is what is your management, don't forget information gathering, because not only because it is a domain that is that you're being assessed, but for your management, you would want to know background information of the patient. So you start from history, even though the first question is how will you manage this case? And more so because information gathering is there as a domain. So you don't want to get a 0 in one domain. Okay. So look at the domains which are assessed in a structured discussion, for that matter, in any station. Okay. Even like in teaching station as well. Information gathering sometimes is a domain. Sometimes it's just communication with your colleague and patient safety applied clinical knowledge. But sometimes there is information gathering. That means that particular colleague of yours, the junior of yours, has come with a case, and you would need to ask history about that case and then teach the patient, teach the colleague. Look at that. Look at the domains in teaching task. That is very, very important. Okay. Then, what further management question is asked in a structured discussion? We will just say the clinical management and stop. We should remember that there is clinical governance and there is counseling as well. Who is going to talk to the patient? Okay, that counseling part is another aspect. Like there is a patient with preterm labor and there is a structured discussion. How will you manage? Everybody will say tocolysis, steroids, magnesium sulfate, blah, 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 blah. Confirm neonatal bed. You have to mention counsel the patient and get the neonatologist to talk to the patient. Okay, so that is important. So divide your management of structured discussion in counseling into three parts: counseling, clinical management, clinical governance. Okay. Okay. So now let's go to opening a station. So now basically a station has say 4 components: this is a simulated patient task that we are talking about. Introduction, agenda, history, management, typically. Okay. So first, in the 2-minute time, understand the task, understand that the patient situation, assess the role player mood, which we have already seen in the beginning of the session today. So how will you start? Hi, I'm Dr. Ankita. I'm one of the doctors here. See, this is another important thing that I was referring to. Instead of saying I'm one of the doctors in the clinic, I'm one of the doctors in the ward, one of the doctors in the A&E. No, just say one of the doctors here. Okay. How may I address you? May I confirm your age? Okay. Just ask her. Instead of saying what is your name and then asking her how may I address you, just ask her how may I address you? May I confirm your age? Again, this depends on the situation. If she is in trouble, if she is in pain, she's breathless, please say, hello, Mrs. So and so, I can see that you are breathless. Is there something that I can do to help? That is a different way of starting. Okay. Then, okay, now coming to a simple station where the patient is comfortable. Okay, then you go to the next thing. So you say, I believe you are here. It may be we discuss reports. It may be because GP has sent her, whatever it may be. So you say, I believe you are here to discuss reports, or I gather from your notes that this is the thing, or I have gone through your GP letter. Can you tell, is it okay if I ask you a couple of questions? Okay, that becomes your permission taking. Or I know you have been referred by your midwife. Is it okay before discussing further? I ask you a couple of questions. That's important. Okay. Remember, you don't have to really say, okay, I've gone through your GP letter. I believe you have a lump coming out of your vagina and there is urinary problems and you are a smoker and your weight for height ratio is high. No, just say, I have gone through your GP letter. Stop there. That will tell the examiner, that will convey to the examiner that you are aware that there is a GP letter. Correct? It is ultimately, the task is to convey to the examiner that you know your task. Okay. So just say, I've gone through your GP letter. I am aware of your situation. Is it okay if I ask you a couple of questions? Then you go and ask an open question for her to speak out. Okay. Then, yeah. So the last question is here. Can you tell me more about your complaints or your situation? So that is how you would go. So first, hi, I am so and so here. How may I address you? May I confirm your age, please? I believe you are here. Agenda because of this. Permission, and then an open question. That is how you do it. Special situations like if there is a young girl, teenager, change of tone is important. So, hello, is this so and so I'm speaking with? So, how are you today? Are you studying? Okay, inquire about her, a bit of a friendly tone or a friendly attitude, right? And also remember confidentiality. They would come with some gynec problem, so you need to ensure confidentiality. All right, so that's important here. SRH module, subfertilities, remember signposting and confidentiality. I know that signposting, all examiners may not really want you to signpost before asking a sexual history. I know that in the exam that was conducted in the UK, some of the examiners said, why are you signposting? Well, it's sexual history. You need to ask sexual history, so ask sexual history. Understood. But there will be examiners who would expect you to signpost. Okay, so you can assess, and it's better to signpost before asking sexual history. They cannot cut your marks. Okay, so that. Angry husband, remember to first confirm that this is the husband that you are talking to. Okay, even if the husband is yelling at you, please first confirm that you are so and so, husband of so and so, and then say, then calm him down. I am so and so. I am here to address all your problems. I'm here to speak to you about your wife. Okay, but first thing, confirm that this is the husband of so and so that you are talking to. Then special situation like cancer, IUD, have a low voice, empathy, okay, and start by saying, if the patient already knows, I am so and so, I'm aware of your situation and sorry that we have to meet under such circumstances. Okay, so this is how you can open certain stations. Now, coming to agenda. Now, some of us are quick at communication. Okay, we don't have a problem. Some of us struggle with forming sentences. It's okay to omit this. If it is not important. Like, you know, the patient in the maternal medicine station, which is anyway a lengthy station, is come to discuss her pregnancy care as she's having a disease. You know that, right? So, I mean, everybody knows that. So, there setting such a long agenda is not so important. Yes, of course, you have to ask her permission, ask permission to take her history. You have to say that I would then formulate a plan for you. But as long as you don't have to, it doesn't have to be such a long agenda that you are setting in, so it's important to have it short. And if you think that you're going to take a lot of time doing it, you can just ask permission. At the end, you can ask if she has any specific concerns and then move on. Okay. These things like, let me examine that, I will first take your history, then I will examine you, then I will go through your investigations, then I will give you PIL and blah, blah, blah. Some of you will say PIL even when you don't know what the station is about. You cannot be doing that. Okay. The patient has come with some vague complaints of pain. You cannot say in the beginning that I will give you PIL when you don't know what you're dealing with. So that is different about setting the agenda. Okay, you can set agenda on such certain stations, but it is not really required to do it in all stations. And if you are struggling with the language, you're struggling with communication, please keep it short. First, just ask her permission for history. Then maybe at the end of history, you can ask her concerns. If you think your examination will help you in the management, then say examine. And then at the end or in the middle of the station, when you realize what the station is about, you say PIL. Okay. Now, again, another point is whether examination is to be offered in all stations. No. If it is a counseling station, you don't have to examine her. Patient of PMS coming to you with mood symptoms, you don't really have to examine her. You just have to counsel her about her mood symptoms. Okay. Patient has come to you with, say, a report of cancer. You don't, where the already biopsy is done, this and that. So, vulval biopsy, for example. You don't really have to go in and examine again, unless the patient is saying that, I have some issues, I have bleeding and this and that. Then yes, but otherwise, it's about counseling. Stick to the counseling part. Okay. Because I know that a lot of you would say, I will examine you in the presence of chaperone. I will do a general physical examination. I will check your pulse. I will check your blood pressure. I will check your per abdominal examination, tummy examination, any tender areas, and down below to see blah, 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 blah. That is not really required, particularly if it is a counseling station. You're just wasting your time. If it is a urogyne station where your examination will change, will change the management, then yes, then that is important. Okay. If it is a station of AUB where you're suspecting, say, fibroid, then yes, but not in a counseling station. Avoid doing it in regularly in all counseling stations. All right. Then, okay. So this is what you should have a template. Now, by now, you should be very thorough with history taking. Most of you are, which is a good thing. Most of you who we are assessing are quite thorough with history taking. Okay, but don't ask irrelevant history. Ask what is relevant. Ask what is going to change your management. Okay, so this have a fixed template. Everybody can have his or her own template. So first start with assessing her background info knowledge, like what she knows. Put an open question. What can you explain to me what your condition is about? Then elaborate on the chief complaints. Okay, like for example, urinary complaints. The patient has come with SUI. Can you tell me about your complaints? If she doesn't tell you everything, then you ask specific questions. Do you have urgency? Do you need to rush to the loo? Do you leak while rushing to the loo? How many times during the day do you pee? So these things you can ask about, elaborate on the chief complaint. Then the relevant complaints. Any other, like, is there a problem with passing stools? Is there pain? Okay, these are relevant other complaints along with the chief complaint. Then go to your rest of the history: obstetric history, menstrual history, medical, surgical, medications, contraceptive, family history. SADAS is a mnemonic that we were using for smoking, alcohol, drug, allergies, reports, smears, sexual history. BBB is blood group, reservation to blood transfusion, and BMI. So these are the histories that typically take at the end. And of course, mental health is important in most of the chronic problems. Okay. So yes, so those are this is what is important in history. Then when she finishes the history, you just thank her that she has given you the history. Please don't go to summarize, particularly so if you have a problem with communication. I mean, if you have a problem with framing sentences. Okay. I know there are a lot of questions coming. I cannot be answering all the questions right away. As I mentioned in the beginning, please put all your questions in the main group. I will be happy to answer them there. We can have an elaborate discussion on the main group. Okay. But since there are many questions coming, I would not be in a position to answer all of them. It may not be fair to the others. Okay, so please, I'm sorry if I'm not able to answer. I will answer all the questions in the group. Okay, I can send a voice recording also if you need a answer in that manner. Okay, so then, so don't summarize. Don't summarize, because ultimately when you're summarizing, you're saying the same points that you have already elicited in the history. So you're not getting anything extra there. Okay, you basically, as I mentioned, it is a tick box exercise. So you need every word that you say, you should be ticking a box in the examiner's key. That is the secret behind passing part 3. So if you summarize, if there is a lot of things in the patient's history, okay, like she's a smoker, she's obese, she's having constipation, she's having SUI, she's having urgency. Are you going to summarize all of that? No. So don't summarize. Just thank her for the information. Ask her, is there anything you would like to add? And then ask her this magic question, that is, explore any specific concerns. So do you have any specific concerns? Because if there are any specific concerns, you can address them there and there itself. Like, let me give you an example. If there is a condition like, say, sickle cell disease in maternal medicine, and she is basically concerned about the risk of transmission to the baby. So if you ask her, if you know this concern of hers in the beginning, you can say, yes, so can you tell me, you can ask her, what are your specific concerns? So she would tell you that, doctor, I'm really worried about whether my baby would get this condition. Okay, so when you know that this is the concern that the patient has, you address that in the beginning. So that particular, you tick the box in the examiner's answer key. Okay, so it's very important to understand what it is. You do that first and then go to the rest of the station. All right, because she would be concerned about this thing. Okay, so first cover that. Then in the management part, just roughly, don't forget MDT wherever applicable, but don't say MDT in all cases. Okay, whenever it is required, wherever required, particularly in the super specialty module, general gynae module, antenatal module, usually will not have MDT. Maternal medicine, where there is a medical disease in pregnancy, will require MDT. Antenatal module, you require consultant obstetrician. Gynec module, these are basic modules. Okay, basic obstetrics, OB-GYN modules. You will usually not require MDT. Okay, you will require MDT when there are complex problems, or where there are problems like in the super specialty modules, like your subfertility is the fertility center, not necessarily MDT, but oncology, then your urogynecology. These are the modules where you would always require an MDT, almost always. Okay, so that. Then referral to specialist wherever applicable. It is important, like for example, Down syndrome screening, high risk for Down syndrome. You say that I would need to do a needle test. You tell her everything about the needle test, but you forget to say referral to a specialist. Then you would lose on safety. Okay, so that's how important it is. If it was a structured discussion, typically communication with colleague is assessed. So if you forget to say I would refer to a fetal medicine specialist or at a fetal medicine center, you would not score in your communication with. It's very easy to lose on communication with colleague, because there are a few things that you need to mention: MDT, your referral to a specialist or counselor, or your the way you talk to the colleague, that if it's a simulated colleague task. Okay, so your allotment of tasks in labor ward prioritization, very easy to lose marks. There are few things to say, and since if you forget to say those few things, you would lose your marks on communication with colleague. So it is very easy to score, at the same time it is very easy to lose. Then Remember omission or addition of drugs wherever necessary, and it is important to say it. Like post-op AKI, patient is on NSAIDs. I will omit NSAID. If you don't say it, you lose on safety. You know that you have to omit, but if you don't say it in the station, you will lose. Okay. Similarly, a patient is on HRT and now she was secretly using HRT. She's got operated and now she has DVT. You took the history that she's on HRT and you did not tell her later because you were busy in managing post-op and post-op course for her and talking about HDU monitoring, talking about scans, CTPA and low molecular weight heparin and blah, blah, blah. And you don't remember to say I would stop HRT. Again, you would lose marks on safety. So that's how it is. Okay. Identified risk factors have to be addressed. Very important for you to understand. Okay. So if you pick up that there are certain risk factors, smoking or your high weight or some estrogen therapy that she's on, and you know that these are risk factors to whatever problem that the patient is, you do not address those risk factors, you lose marks. Okay. Urogyne will, again, it's a super specialty branch, which is why they will typically give you patient with risk factors so that you know the basics at least. The basics have to be covered thoroughly. You tell her everything about the procedure. You tell her that she'll require MDT and she'll require posterior colporrhaphy and she'll require wall suspension and this and that. But you forget to tell her that if she's obese, that wall suspension will fail unless we cut down on obesity. You will lose marks on safety. That's very important to understand. Okay, that is why obesity is one of the hidden agenda, and not the hidden agenda is one of the factors. And in your exam, you can expect at least 3 or 4 stations to have obese patients because obesity is a pandemic now. Okay, then PIL is something that I would request all of you to say somewhere in the middle as you're doing the station. Don't keep it for the end because it's a very important point and it is possible that you would overshoot time. And then whatever you say after the 10th minute is not counted. Okay, so you say it somewhere in the middle, like if you have counseled a patient regarding maternal medicine or disease, and you have told her that this is what can go wrong in you. Then just say that I know I'm giving you a lot of information. I will give you some written leaflets to read. Okay, so that particular box in the examiner's key, PIL, will be ticked. Okay, so that's how it is. Remember red flags wherever necessary, follow-up plan, contraceptive, as I mentioned, contraceptive advice is something that most of us forget. So that should not happen. Support, counseling, documentation, discuss with the consultant, appointment, write back to GP, write back to midwife, all that. Okay. So this is an overall overview. You can just remember this particular slide and think of whether these points are relevant to the stations that you're doing. Let's come to modules. Early pregnancy module, BBN wherever necessary, red flags, pain, bleeding, giddiness, shoulder tip pain, remember them. If there is RPL, refer to RPL clinic. This is another point that you should remember. Folic acid, don't forget. Booking investigations, at least say if she's come early in pregnancy. Then contraception in case of failed pregnancy, molar pregnancy, ectopic pregnancy, salpingotomy. When you do, you have to talk to her about contraception till it heals at least for 3 months. Support, PIL. So these are important points in early pregnancy. Remember these points. Subfertility. Okay. Empathy, because they are trying to conceive and say that I know that may be stressful. Like if you want to, some of us have this problem, how to say counselors support in subfertility or in any such module. You say that I know going through all this can be stressful. We have counselors for you. Okay, that's a particular typical statement that you can use in all modules. Okay, STI screening, subfertility module, remember, smears, support, signposting, okay, before sensitive issues, confidentiality, okay, very important. Whatever relevant investigations, referral to a fertility center, mentioning that is important. that I would refer you to a referral to a fertility center. As I mentioned earlier, if you don't say fertility center, you tell her everything about the treatment that you're going to offer, then you will lose on your that particular domain. Then remember, options of surrogacy and adoption can be open to all. Okay, so that's something. Even if the patient can undergo a test tube baby, like both the tubes are blocked. HSG is showing both tubes are blocked. Maybe a laparoscopy is also showing both tubes are blocked. Then you think that test tube baby is something that you can offer her. Yes, you can offer her a test tube baby, but you can also give her the option of surrogacy and adoption in all cases. Okay. Remember, child welfare issues are most important, and this can come in maybe a structured discussion sometimes, where the examiner would ask you, so what are the various aspects that you would look into while you consider funding for IVF or whatever. Okay, child welfare issue is the most important point there. Like, for example, if it's a couple with in a same-sex relationship or a single parent, they would really be, before funding her IVF, they would be worried about how the child would be brought up. So the welfare issues would have to be looked into. So this is an important point. Okay. Antenatal care. Antenatal care is basically, remember, obstetric complications that happen in, you would get stations where there are obstetric complications in the pregnancy. Maternal medicine is maternal diseases in medical diseases in pregnancy. Okay. Antenatal care would be placenta previa, PET, and all those things. So here there are certain drugs that are given in the antenatal period. First of all, hardly any. So, but if they are indicated, don't forget to say those. Aspirin, low molecular weight heparin, folic acid, wherever applicable. If you forget aspirin in a situation where it is to be given, you would lose on patient safety, because it is a star point. It is a very important point in management. Okay, because there are hardly any indications for aspirin, for that matter. Okay, unless of course there is a maternal medicine, medical disease, which is a different module altogether. Then, so remember, screening, Downs, anomaly screening, diabetes screening wherever indicated, 24 to 28 weeks, SGA screening wherever indicated. Okay, remember these things when you are making a plan for her. So first think of the drugs that you would have to give her or not. Then think of screening in antenatal period. If there is a complication in the antenatal period, you don't forget to say consultant level follow-up. Okay, consultant level follow-up, delivery in obstetric unit. In maternal medicine, this is something that you can use in all maternal medicine stations. Consultant level follow-up, more frequent visits, delivery in an obstetric unit. Okay, then maternal medicine, difficult module to cover. I would suggest you should stick to the template. There is a definite template of maternal medicine, which involves introduction. Agenda can be short, as I mentioned earlier. History, concern. I'll add one more thing over here. What is the patient's concern? Like I mentioned about the sickle cell disease. Effects of disease on the pregnancy and vice versa. Then go to management. If it is preconception, before pregnancy, first. Don't keep it at the end, which most of us do. Preconception period, you talk about antenatal management, intrapartum management, postnatal management, forget about the preconception. That should not happen. Before pregnancy, antenatal, intrapartum, and postnatal. Okay. Then say generally, in women in situation like yours can have a normal or straightforward, not normal, straightforward pregnancy. But this cannot apply in all situations. Do not say it if there is a patient with severe pulmonary hypertension who's come to you with pregnancy. You cannot be telling her, where the mortality is almost 30%, you cannot be telling her that most of you would have a straightforward pregnancy. Okay, so remember, be mindful of the situation. Okay, then MDT, always required. Then the points that I have mentioned there: consultant-led care, more frequent visits, delivery in the obstetric unit, referral, review of medications, important, wherever applicable. If you think you don't know a particular medicine is safe or not safe, say I would refer to the BNF, or I would ask my consultant, I will seek opinion regarding this, I would get back to you. But then don't get worried that you don't know about the safety of a particular drug. That's fine. If it's an uncommon drug, they would give you the BNF there. They would give you the data on the drug in the station. Okay. So and again, remember your aspirin, folic acid, low molecular weight heparin, screening wherever applicable. Okay. So this is the basic stem that you have to remember in this station. Then labor and delivery in labor station. Now labor ward prioritization, I have done almost a 2-hour class, which is, and I've highlighted certain important points here. I'm not going to go into depth of that. This is patient in labor and say negotiation station or counseling about labor. There will be information gathering that you would need to do, but that information gathering need not be extensive because the patient is in labor. So you are not going to ask her about family history. You're not going to ask her about smoking, alcohol, drug abuse, etc. You're going to ask her about her limited things that you would help you in managing her, like obstetric history, medical diseases, surgeries, previous surgeries like previous cesarean, support. Support would be birthing partner, allergies. Allergies is very important. BMI, blood group, reservation of transfusion is very important in labor. Okay, of course, you can maybe ask her if we have a name for the baby. Okay, whenever it is a negotiation task, ask why she wants a particular, if she wants home delivery, why does she want home delivery? What are her thoughts? What does she know? That has to be explored. Okay, explain the modes of delivery and the risks associated. And in a negotiation task, do not forget to say the worst possible outcome for the mother or the baby. Say that this is a life-threatening problem that can happen to you. If it's twins who's delivering and she wants delivery at home, you can tell her that the second baby may die if the cord prolapses out and we don't have immediate cesarean facilities available. The second baby would require maneuvers to turn the baby sometimes in the womb. Okay, so and say phrases like every minute counts. Okay, so it may take you a while you're being shifted from home to the hospital. Okay, and also don't say PIL in advanced labor. If she's in early labor, she still has time, then you can say PIL, but don't say I will give you PIL in when the patient is in second stage of labor. Patient cannot be reading in second stage of labor. Then general gynecology module again may have certain hidden agenda like high BMI. The lady with atypical endometrial hyperplasia had been on herbal medications in one of the RCOG courses. Also, I think in the exam. Okay, so herbal medications are over-the-counter medications may contain estrogenic drugs. So you need to stop those. You need to ask them if they are using any over-the-counter medicines. All right. So remember that. Remember to ask about fertility wishes, particularly when you're dealing with fibroids. Okay. And uterine artery embolization is not entirely safe when the patient is wanting to preserve her fertility, although the NICE guidelines will say that it will allow preservation of fertility, but it does not say you recommend uterine artery embolization for those wanting to preserve fertility, because there are potential complications that can happen in the pregnancy following a uterine artery embolization procedure, which could include stillbirth, prematurity, and placental problems, okay, and PPH. So that is why need to ask fertility wishes when you are considering or when the station is in a gynec station for that matter, because your management will change. Then remember to treat other conditions, like if there is AUB, remember to treat anemia. That's important. If you do not treat anemia, you would fail on safety probably. And also remember if there is AUB, like for example with fibroids, you think surgery would be the recommended mode of treatment, and there is anemia, you need to buy time to treat the anemia. Okay, so you can put the patient on an interim method of a medical management and treat the anemia. Okay, so that is important for you to remember. Empathy. Okay, whenever there is a chronic problem, gynec problem, empathy is important. Okay, as you can say, I'm sorry to hear that. I know you're going through a lot. I will try my best to help you. Enough. That's enough. And go ahead. Okay, you have already ticked the box of empathy in communication with patient. All right. Then again, have situation specific treatment. When there is fibroid, which is say 16 centimeter size fibroid, you will not tell her about not bleeding. You will not tell her about OCPs. You will not tell her about progesterone only management. You will probably talk about surgery. You would probably talk about yeah, that's what, only surgery, hysterectomy or surgery. Okay, very unlikely that a medical line of treatment would reduce the size of the fibroid. Fibroid that bigger size having pressure symptoms. It's not possible. So just because the fibroid guidelines would say all these treatment options doesn't mean that when there is a case of fibroid, you offer all those treatment options to the patient. It has to be tailored to the patient situation. So that's important. Then support counseling. These are important points. Most of the chronic cases, chronic problems that the patients have. PMS, okay, important. Asking about quality of life, whether it is interfering with quality of life. If it is quite obvious in the station that it is interfering with quality of life, please don't go and ask her, is it interfering with quality of life? Okay. But if she's fine and if she's not sounding upset, and you can always ask the question, so how is it affecting your day-to-day life? All right. So and if she has problems and she's saying that no, this has been a problem and this is affecting my day-to-day routine and this is affecting my sex life, this is affecting my work life, then you can always make a mention that I can see that it is affecting your quality of life, because the moment you say that word, examiner will tick that box. Okay. So then, and PIL, of course, PIL is important. Then oncology. Oncology is first you need to know what the patient already knows. Patient may be knowing about the diagnosis, patient may not be knowing about the extent of cancer, may not be knowing about the stage. Okay, like for example, in the station with vulval cancer, patient had come with the biopsy report. I mean, she has come for the MDT opinion, and she knows that it is cancer, but she doesn't know the MRI which was attached there, and the MRI says that there is invasion into the bladder. So first you need to ask her whether she knows the MRI. Okay, it may not be very clear from the station whether she knows or not, doesn't know, may not be very clear. Okay, so you first need to ask whether she knows the report. Establish what the patient knows is important. Then explain to her the report. Again, BBN. All right, Breaking Bad News template. And empathy, MDT, relevant investigations, tumor marker, CT scan. And another important common mistake made is you say that we would refer you to the MDT and they would do a scan. No, it's the other way around. You do the basic investigating the patient part and the MDT would give their opinion. Okay, so you say that we would do a scan for you, a CT scan, and then refer you to the MDT. It's not the other way around. All right, then documentation. This documentation bit is important in all stations. You can say it in all stations. In the end of the station, when you say, I would refer to the GP, give you PIL and all those things, you say, I would document this consultation also. All right. So PIL documentation, remember. Then the next module will be sexual and reproductive health. Here, remember, you have to be sensitive. Okay, you may be dealing with a say 9-year-old child, or you may be dealing with a single vulnerable population. Then need to be sensitive. Okay, you need to sound sensitive. Have a low tone. Okay, signposting important, confidentiality, safeguarding issues wherever applicable in rape cases, etc. If you are unsure as to if the patient doesn't want, if she is a major patient, she may say, I don't want to file a police complaint. Then you can always say, I would discuss with consultant and involve the safeguarding, particularly if she is the vulnerable population, like it's a gang rape. Okay, then that's an offense which cannot be pardoned. Okay, if she's a major and she's raped by her boyfriend, that's a different thing that she doesn't want to do, make a file a police complaint. But if it's a vulnerable population, or if it's something like a gang, just an example, okay, and you are quite unsure that you think that it is safe for you to for you to talk to the police, then I mean to involve the safeguarding, it is always best for you to involve the safeguarding. All right. So offer safe contraceptive advice. Remember, in emergency contraceptive, patient asking for emergency contraception is a very common scenario that is asked in the exam. So important. Okay, so make sure that you take a proper history, whether the cycles are regular, what phase of the cycle she's in, whether she's already ovulated, what is the possibility that she's already ovulated. Then you know that the medical, that is your LNG and your ulipristal will not work. So those things you should be careful about. Then a young girl with suspected abuse, you should say these 4 C's: confidentiality, consent. Okay, whatever you do, whether there was consent, consensual intercourse, whenever you examine her, ask for consent. Capacity, contraceptives, mental health, mental capacity, and contraceptives. So these are the C's that you would look into when you're doing a sexual reproductive health module station. Core surgical is, this is a module where you may be asked consents, taking consent. Okay, so when you take consent, remember to identify risk factors that she
Slide
may
is
be
not
having.
changed.
Oh, okay, sorry. I think it's all right. Okay, it's changed now. So if there are risk factors, identify the risk factors, tell the patient, make sure that the patient is already aware of the alternate options that she has. Like if you are doing a hysterectomy for fibroid that is bleeding, make sure she knows about other options like GnRH analogs, uterine artery embolization. Okay, so that has to be asked in history. And check if there are any major risk factors that she has that you may have to modify. Okay, and remember the pillars of consent taking. It has to be voluntary, so you have to be voluntary. It is implied when the patient is talking to you and understanding and communicating back. That informed means you have to talk to her about all the problems that she can have. That applies to all stations, all counseling stations, like all labor stations also. When you are talking to her, talking to a patient, you have to give her the necessary information that she needs to know in order to be able to take an informed decision. And she has to be mentally competent, of course. Like the case of Alzheimer's patient cannot be giving consent for a procedure. So you need to have another person. I mean, cannot sign for the consent, but you need to talk to the other person and maybe ask for a lasting power of attorney. And whenever there is consent taking station, which is likely that it is likely that they may ask you, because this is after a long time that we are having face-to-face exams. So they may ask you a consent taking station. Please sign the form. Just scribble things on it. While you are talking, you can scribble and pretend that you are writing the consent form. But important is to sign the form and ask her to sign there where the patient's signature is. Okay. And for core surgical module, also remember principles of enhanced recovery. This is important. This can come as a station. It had come as an audit station. Post-op, you remember the relevant care bundles. Post-op complication would be asked generally. So like a ureteric injury, then your sepsis. These are common ones. So remember to say sepsis 6 care bundle. If it is placenta previa in antenatal module, remember to say placenta previa care bundle. Cannot forget that. Whenever there is a patient who requires resuscitation, start with ABC, airway, breathing, circulation. Okay. And the relevant points like IV line, oxygen, antibiotics, nil per oral, all those things. And a post-op module, also remember the routine, just not the complication, the routine post-op history that we ask. How is the pain? Has she been mobilizing? Has she passed flatus, passed urine, passed stools? Okay. How is the wound? Okay. All those things also you remember. Okay. Postnatal, we would, this is what we used to do when we were studying. We would remember A, B, C, D, E, F. So you have your A for analgesics, antibiotics, anticoagulants. These are whatever is necessary, may be necessary in the postnatal period, wherever applicable for that matter. So analgesics, antibiotics, anticoagulants. B is breastfeeding. Okay. These are the components that you need to look into in a postnatal patient. Contraception, whenever later at discharge, you have to talk to her about contraception. D, DVT, documentation, dietetics, debrief, discuss. E is expert opinion. If she has a problem in the antenatal period or whenever you would seek specialist opinion, that is expert, and follow-up care plan. So this is how we would remember our postnatal, the points to be covered in a postnatal module. Teaching module. In teaching module, again, have a friendly repo, and there are certain things that you would need to ask, like always start by saying, hi, I'm Ankita, I'm the ST5, and you are so and so. So how have you been doing? So this is repo building. How have you been doing in the department? Are you happy? If there's any problem whatsoever, you can always come to one of us and we would be happy to help you. All right. And also note the role player's body language, because if it is a bullying station, a station on bullying, then you should be careful and note the body language. If she's uncomfortable, she's hesitant, and she's not talking well, okay, then you may think that it's maybe a bullying station. Okay. So all those things, if you do have any problem, please come, feel free to seek help, etc., etc. And so then you say, I believe you want to learn about, say, forceps. Okay. So first ask why. What happened, that what triggered this thing. Okay. So why she wants to learn about forceps. Have you read about forceps? Have you seen forceps? Okay. So this is assessing background knowledge, because if it's important for you to know what what your the colleague already knows or already has done. Okay. And in a teaching task, it is important to ask, what do you know? What do you want to learn about forceps? Remember, forceps in that station you have to cover in 10 minutes. You can have a lecture on forceps in 1 hour. So it is difficult for you to understand what exactly the station is assessing. What part, what aspect of forceps is being assessed in the station? Who is going to tell you? Your role player. So you ask the role player, what is it about forceps that you want to learn? For that matter, any teaching task, if it is CTG, ask, what is it about CTG that you want to learn? It may be just simple interpretation. Okay, it may be prerequisites for CTG. Okay, so if you don't say those and you have told her everything about interpretation, including all the classification and the nice guidelines, you would still not score good, because you have missed one particular aspect of CTG, that is the prerequisites. Okay, so that is why it is important to understand what that teaching task needs you to address. Okay, so what is included in the answer key? That is, the role player is going to tell you, the colleague is going to tell you. So you need to ask, what is it about forceps that you want to know? Okay, pessary. What is it about pessaries that you want to know? Okay, then ask them to repeat whenever applicable, but don't ask them to repeat in the end of the station after having spoken about everything. Okay, so can you tell me what are the highlights of the session? No, that cannot happen, because you are just wasting your own time. You give her a small thing to repeat, like you tell them to repeat, say you have mentioned the prerequisites of forceps. So can you tell me prerequisites of forceps? One or two, or she'll say something. So then move on with the station. Okay, but don't tell them to repeat what has been learned in the session in the 10 minutes. It's not possible to do that. Okay, then appreciate them when they repeat that. I can see that you are a fast learner. Then ask after every chunk of information that you give, am I clear so far? And this applies to all the other modules as well. So if it's a maternal medicine task, ask, am I clear? Okay, after every chunk of information. So because what happens in maternal medicine is you go on and on and on about the problem, and then you forget to ask if the patient if she has understood. So it's important to check understanding in all stations, even and here particularly because it's a teaching task. And then give her resources to go through, ask for feedback on your teaching session, and tell her that next time I could show you, I could demonstrate for you, etc., etc. So this is about teaching. Then coming to urogyne. Now in urogyne again, lengthy stations, again empathy, sympathy, all that. Then in history, if there is urinary complaints, if there is incontinence. See, if she says there are no urinary complaints, you don't have to ask again, okay, is there frequency, is there hematuria, etc., etc. Because these are not real patients. They are trained role players. If there are no complaints, they will tell you there are no complaints. They are not going to lie to you, or they're not going to hide information. They are not real patients. Okay, so they are role players. So you just ask, first ask if there are any urinary complaints. If there are no urinary complaints, you don't have to elaborate and waste time. If there is a if there is a particular form of incontinence, like there is, say, stress urinary incontinence history, then you have to rule out mixed urinary incontinence. You have to ask about urgency. So does she need to rush to the loo? Does she leak while she's rushing to the loo? How often do you need to pass urine? Okay. Then you have to ask each of these problems. If there is one form of incontinence, ask about the other incontinence history. Okay, other type of incontinence history. Sexual history important because the problem may interfere with sexual life. Then support important because she may be upset, she needs support at home. Smears again important. BMI, chronic cough, constipation, risk factors, smoking also important, and occupation. Okay, and whenever there is a occupation where she has to lift weights, etc., etc., you can talk about occupational therapy, and that you could we could have a referral to the occupational therapist, etc. Quality of life is important, but if she is complaining and whining about her problem, just say, oh, I see that it can interfere, it is interfering with your quality of life, so sorry to hear that. Okay, but if it's not obvious, you can ask a direct question. So is it interfering with your quality of life? Okay. Then mental health. So in the past few weeks, have you felt low or depressed? Important. Interpretation of urodynamics is a different thing altogether, so important. Urine routine, bladder diary, lifestyle measures is something that you need to mention whenever there is a urinary problem. Okay, so this is very important. Don't forget. I know that again, urogyne can be long stations, and when you think of SUI, and there are so many problems like obesity, this, that, and you're all the time thinking about addressing her obesity, addressing this, that, and you forget the basic thing, that is doing a urine examination. That should not happen. Okay, that is why that is put as a separate point, so that you remember. Okay, urine examination, offering urine examination is important. Bladder diary, of course, when it is an obvious SUI, you need not, but it is better to, most of the times, it is better to offer a bladder diary. Okay, ask her to maintain a bladder diary. All right. So yes, that was my last slide. I hope I have not taken too much of your time, and I really hope this helps all of you. I also know that there are a lot of questions. I'm not quite sure if you could please put all of these questions on the group. It would be lovely, because if there are too many. All right. Let me see if there is anything that I can address.
Ma'am,
Thank you
oncology.
so much, all of you. Yes. Hello.
Ma'am,
Yeah, we'll send a recording. Okay, I'll send a recording. Size of uterus or fibroid for which vertical incision is required? No, nothing like that. It depends on your clinical judgment. Multiple unprotected sexual intercourse property is contraindicated, provided you have you are more than 5 days from the earliest possible ovulation, because you don't want to be disturbing an already established pregnancy. Otherwise, just because there are multiple episodes of intercourse, not required, not contraindicated. Up to what size fibroid medical treatment? Yes, you can offer to less than 3. You can offer to bigger fibroids also. There is no definite way of saying that okay, if it is less, if it's 4 centimeters, medical may not work. But yes, most of the guidelines divides the management into less than 3, more than 3. But then again,